section, we will select some topics which are commonly asked in the FRCS or any exit exam. We will try to compress them in 5 minutes. They will not be comprehensive reviews. They will be short, concise videos. Try to just organize your thoughts in a 5-minute video so you can appropriately address this topic if you are asked about it in a Viva. We will start with adult hip dysplasia. So what is hip dysplasia? It's abnormal development of the hip. It leads to inappropriate covering of the head, so a shallow acetabulum. This leads to unequal distribution of forces, leading to pain and then eventually leading to arthritis. The most common angle used to describe dysplasia is the lateral central edge angle. Less than 20 degrees indicates dysplasia. 20 to 25 degrees is borderline dysplasia. Acetabular index more than 10 degrees indicates dysplasia. History taking, onset of symptoms, longer the duration of symptoms, the higher risk of arthritis, effect on the patient's activities, hobbies, and the current activity level of the patients, their expectations, do they want to go back to playing sports, childhood hip problems, previous surgeries, and family history of hip problems. In your examination, you need to mention that you look at the scars from the previous surgeries. This might affect your approach later on. You would look at the gait. They could have Trendelenburg gait or short limb gait. You need to examine for abductor muscle weakness. You need to look at the leg length difference. It could be apparent leg length difference, could be true, could be femoral, and sometimes they could even have tibial differences. Look at the rotational profile. They're known to have increased femoral antiversion, but they could also have excessive tibial torsion. So your management will depend on the presence or absence of arthritis. Most centers would not just settle for the plain X-ray to exclude arthritis and would perform an MRI scan. All cases will be subject to the standard non-operative treatment that includes activity modification and physiotherapy, hip preservation surgery in a specialist center, that is prior to establishment of arthritis, and a total hip replacement by a specialist after the establishment of arthritis. So hip preservation options, the most common osteotomy done is the Gans periacetabular osteotomy. What is a Gans periacetabular osteotomy? It is a reorientation osteotomy done through a single anterior approach, and it preserves the integrity of the posterior column, but its main disadvantage is that it violates the triradiate cartilage, so not suitable for the skeletally immature patient. So what are the results of the Gans periacetabular osteotomy? Approximately 80% survivorship at 10 years and 60% to 20 years. This was in the original Gans cohort. Poor outcome was associated with older ages, so above 35 years old, and in some studies above 45 years old have lower outcomes. Presence of hip arthritis is another indication, of course, for poor outcomes. Complication rates, they initially had a quite dramatic high complication rate, above 20% in some studies. As the surgeons got more experienced in these surgeries, and with the development of minimally invasive approaches, the complication has decreased, and in some studies it was lower than 10%. So after establishment of arthritis, your treatment would be a total hip replacement. You need to demonstrate that you recognize the complexity of the situation. You need to refer this to a senior arthroplasty who has special interest in these cases. You need to be aware of the various classifications. That includes the Hartog-Achilles classification and the Crowes classification, which you would need to mention the challenges that you will face. So you know that you have a high hip center, you know that you have insufficient superior lateral coverage on the femoral side, you know that you have a valgus neck, you have an abnormal femoral offset, you have abnormal femoral version, usually excessive femoral antiversion, you have a narrow canal with a higher risk of peripatetic femoral fracture, and you might have significant leg length discrepancy. You've got scar from previous tissues. This will make it a much more difficult and challenging surgery, might increase the risk of vascular or nerve injuries. So what are the solutions you're going to propose in the exam? For the acetabulum, you need proper preoperative planning. You need a CT scanogram for the leg length discrepancy. Some centers even do 3D printed models. You would aim to restore the hip center to the native hip center. And you could quote the paper by Lindy. It's one of the classic orthopedic papers, 1988, and restoration of the hip center had better outcomes than a high hip center, and we know that there's more, or there's better bone stock in the native hip rather than the high hip center. Reconstruction of acetabular defects, you can use the patient's femoral head. On the femoral side, you need to restore the version and the offset. The most obvious or easiest thing to mention in the exam is use a modular stem such as the SROM. Leg length discrepancy, you should aim not to lengthen the patient more than 3 or 4 centimeters. Fear of sciatic nerve injury. If you had to lengthen more than that, then you should be inclined towards a subtrochanteric shortening osteotomy. With the shortening osteotomy, you might do a derotational osteotomy. Again, the narrow canal, there's a risk of peripathetic fracture. You need to use narrow stems, and in some extreme cases, you might need custom-made implants. Thank you, and I hope that this was useful. Again, this is not a comprehensive review, as I mentioned. This is just a quick review that you can use to sort of refresh your memory and get everything, get your hard disk formatted or defragmented so that you can demonstrate in the Viva that you know this topic and are up to date with it.